Hi, I'm Caroline Evenden from 10-Minute Medicine, and I'm going to do a presentation today on what to expect when attending a trauma call. So, um, in this situation, you are the TNO SHO on call, and your bleep asks you to attend a trauma call in ED. So, why are trauma calls put out? Trauma calls should only be put out at major trauma centres that are part of the major trauma network. So, if you're not in a major trauma centre, for example, if you're just in a trauma centre or a place within the ED, it's important to know where your nearest major trauma centre is and how to contact them, because sometimes accidentally major traumas don't come in as trauma calls and go to the wrong centre. But the trauma calls that are put out are normally for injuries, for example, like polytrauma, open fractures, pelvic fractures, spinal injuries, and intracranial injuries. So who goes to the trauma call? So normally a pre-alert is put out by the pre-hospital medics who alert ED that a trauma is coming in, which then will go through to the bleep for anyone who's part of the major trauma team. So the major trauma team is normally made up of ED, normally a consultant, gen surge, TNO, and anaesthetics or ITU. And this is normally an SHO and a reg from each team, depending on the rota and how big your trauma centre is. Sometimes trauma patients don't come in by ambulance though, and won't come in as trauma calls, for example, if they've come in by foot, being brought in by somebody else, or sometimes ambulances don't put them in as trauma calls. And in ED, you might see a patient that you think is a polytrauma and needs to be dealt with as a trauma call. So you can put a trauma call out in ED as well. So what happens at the trauma call? So once you get down to the room, it'll be in resus. You'll have the whole team there, because you've arrived ahead of time before the patient has arrived. Normally introduce yourself. At the hospital that I'm at, everyone gets labels, so you know everyone is part of the team, and to make sure that every specialty is there who should be there, and everyone's assigned roles. So normally a specialty is assigned the same role each time. For example, your role might be to do the primary survey, it might be to get IV access. And then A2E assessment is done with a primary and a secondary survey. The important thing to know is to be silent during the primary survey. Whoever's conducting the primary survey will talk out their positives and negatives, and the scribe will be writing it down. And most patients will go for a trauma CT, which is a head-to-toe CT to look for any injuries. So it's important to note that obviously as an SHO, you're not going to be running a trauma call. There's going to be lots of senior support there. So don't panic, don't worry about going to them. Just stay calm, know your assigned role. And if, for example, your assigned role is IV access and you're unable to get it, there's always going to be someone more senior there that can help you do your job. And mainly it's a learning experience because not much is expected of you, but you can see how trauma patients, very sick patients, are dealt with. So you're most likely not going to be doing the primary survey. Maybe when you become more familiar with the department and more experienced, they might ask you if you want to do it. But it's important to know the advanced trauma life support algorithm, because this is how the A2E assessment will be done. And knowing the algorithm will obviously help you also pick up on what's going on, and your job might be order the scans, order the bloods, print the labels, and things like that. So this is a very whistle-stop tour to what expects in a trauma call. But the most important thing is you know where to go when your bleep goes off, and you know the job that's assigned to you.